they also knew this, that the IVIG is going to make them feel better for some time. And they followed up right away to say, how are you feeling? And the patient said, feeling better. And a month later, patients went back to remission when the antibodies were removed by the body.
Right.
Then when the patient said afterwards that please follow up, we are not feeling well, they just stopped all communication. So they had the data that correctly and accurately says that patient is feeling better. But I want to say some bad words here, but the messed up part in this is they didn't do the follow-up, which would have shown that almost everyone is still suffering.
Yeah, no, I mean, this was, like I said, it's just so disturbing because, I always felt that the way they've been controlling the information as far as, the absolute, like the vaccines can do no wrong. I felt I gave it to them as it was their public health. Like they were just trying to do good for the most people, and you didn't want to frighten people that yes, there's a percentage of people who will get sick.
Yeah.
And but yet we're saving lots of lives, so it's worth it. It's better that everybody gets the vaccine. But this is just another level of I think it's just too far. It's just,
Yeah. And if you look at this data, it came out, they started this study in January of 2021. Vaccinations and the trials had started from September, I believe, onwards. The actual vaccination rollout in production started in December.
right.
January is when they had the patients. They started them on. By June, they had a lot of data. They actually did not do follow-ups. By September, they just excommunicated everyone. And I can understand if they would talk with them, right? And then they did not publish it till now.
Yeah,
They sat on it.
yeah.
They had the patients since January, a month after the rollout. They had the patients and they just sat on it and they sat on it and then they ignored the patients. So this is what is really weird for me. Uh, Ideally, if you talk medicine, we would have said, so let's say you and I are discussing this at, hey, how do we plan vaccines? We would have said there are going to be some side effects. There are going to be some that we do not even know. And then there are going to be some that we can anticipate. So let's very quickly put together the plans that when that happens, what are the signs and symptoms, indications of a side effect occurring? And let's educate the doctors and the public to say, when this happens, please make sure that here is your therapy. And tell the insurance companies that please cover the therapies on this. Tell the patients that if you have this, please go to your doctors. They know what they need to do next. What they did was they've swept everything under the rug. That made patients, however rare they may be, I think that they deliberately do not provide the correct numbers, and so that they can keep saying rare. However rare these patients may be, they have, this is equal to striking an animal on the road while you're driving and letting it die on the sidewalks, on the wayside, and saying, well, this is a rare event. And there is no help for these patients. There is um, no recognition. Their doctors do not know. Their communities make fun of them. They say this is all in your head. They say this is all psychological. It is such a malpractice that was done that I cannot even imagine it happened at this level and at this scale.
Yeah, and I'm that yeah, I'm I'm speechless by it because I said I really thought that some of it in the beginning, the willful ignoring of side effects, because I said we have measured, you can see that the D dimer after the after vaccination, the D dimer does go up if you measure.
Yeah. And if you listen to the talk from Brie, I believe, one of them, Brie or Michelle, they actually showed that the vaccine debrief document said that there is a possibility, I think this was Michelle, there is a possibility of adult multi-system inflammatory syndrome, and one should be careful and one should report it. And can you imagine, as she was saying, that there is no reporting category for this?
Yeah, no, it's, and what we're looking at, and one of the things, if you're in contact with these people, is a neurologist who's a friend of mine and has, just has a clinic, and they just have 2 apheresis machines, and I have an apheresis machine we're about to put online, and I really think that we need to try this especially for the persistent neurologic effects. I mean,
Yeah,
if
absolutely.
I mean, we don't have, unfortunately, in America, we can't do the apheresis designed to remove the clotting. But I think just because those are filters that they use in Germany, and they're not licensed in America. But oops, I think we're, but I do believe just by removing the IgG and the inflammatory, some of the inflammatory modulators, you can probably reset this, go back to try to reset the system.
You can definitely help the patient by making it better. And it is possible that as the inflammatory state goes down, because antibodies are cleared out, then maybe the cells would reset themselves as well by the regulatory cell getting a chance to overwhelm the bad cells.
Yeah.
So I think these are very valid approaches. And here is the problem. When I'm still stuck on the NIH and NIND and whatever, when they did not offer help, recognition, then of course doctors had to figure out what to do. They don't have a right to then go crying foul when doctors are trying to figure out how to manage their patients.
Well, unfortunately, they will. I think what you're referring to is the very real problem that, that when you try to treat people based on, the evidence and your best clinical judgment, that used to be how medicine was practiced in America.
Yes.
But that has changed, and something has happened in the last, I'd say, probably 20 to 30 years, but it's escalated in the last 10, where you cannot, the academic medical centers are now very good at doing lots of tests and scratching their heads and understanding, but not treating, because there's no double-blind placebo-controlled study, so they will not treat without that. Anyway, so it's become, and the unfortunately, the people who monitor or who make rules for medicine in America are only, too many of them are doctors who don't practice and administrators.
Yeah. And I think our society is litigious as well. So doctors try to, this is me saying hello to everyone.
Oh yeah, we're about to do that. I was waiting till the noon hour. The rest of you have been listening to Dr. Bean and I. Funny calling you Dr. Bean, but okay, I will. It works.
It works. Everybody calls me that. I'm totally good with it.
Keep on calling you Dr. Said, but okay, Dr. Bean and
Dr.
I.
Bean is good.
Discuss, a recent study that he did an amazingly clear job of dissecting on his podcast about what the NIH and persistent neurologic symptoms. But so I encourage you all to take a listen. I don't know what episode that was. But I think it's really important that people listen to that and understand that, God, I don't want to say this, but I think unfortunately we're in that position where we're going to be taking care of each other, and we're not going to be as dependent, I would, on the NIH for help as I hope we would be. I'd hope that they were really beginning to take this more seriously than they have things like chronic fatigue and chronic Lyme disease.
So if I read the tea leaves,
Yeah.
Eric, I think that they are going to do it now. Do you know why? I think that they have done what they wanted to, and that is hide the information, suppress the information till people are vaccinated. I don't think they're going to get more traction on vaccine in the coming days. Now, these studies that are coming out of NIH, why are they coming out now? They
Mm.
had the data in June. This is almost the June. Why are they doing it now, a year later? Because they know that now we should just do it. Because if they don't do it now, then they will be held accountable to say, why did you hide it? Now they can say, well, we published it. It just took us a year to put the data together and send it out. So I think now they would get back and say, yeah, we know this, that this is happening. We'll help. We'll do whatever we can. This is to cover their own behind.
Yeah, I hope you are right. I am forever optimistic because I do know that most of the people, most of the scientists that I've ever interacted with, in all levels of academia and in at the NIH or gone to conferences, are really good people. They really want to help. So I don't think there's anything, so I am hopeful that we will move forward and they will be an ally in helping people get back to health after, long COVID or vaccine injury. So on that note, today, I was, last time I don't know exactly what you prepared for today because we had plans to talk about
Today
treatment.
is therapy day.
Therapeutic day, yes, but I still someday I still would like to do a deep dive with you, but maybe I'll do it on my own on the Dr. Pretorius's concepts because I do see a lot of I think a lot of the soluble CD40 that we see elevated on Dr. Patterson's panel has a lot to do with the activated platelets and the persistent clotting. But enough, Dr. Mobeen.
Dr. Bean is totally fine.
Okay, Dr.
Everybody's thinking
Bean,
that.
let's take it away and let's welcome everyone. Really, this has just been just such a pleasure to get to talk to Dr. Bean and really pick his brain. And we're going to do more of that today. So let us talk about what can we do for long COVID.
Excellent. So, Eric, thank you very much for having me, and the audience, thank you very much for being here. So today is the Therapeutics Day for vaccine injury for long COVID. And I'm going to go over various protocols that are out there and the main roots of those protocols or backbones of those protocols and how these may be helpful. I think today's session, Eric, in my opinion, out of all the sessions, is going to become the most important, not only because I am speaking, well, I was speaking in the previous ones too, but mostly the links and the therapeutic data that we would share. Because for doctors, that is important for practice. For patient, it is important to understand where these mechanisms are present, where these prescriptions or not prescriptions, but these protocols are present.
Yeah.
So
let me just, for our audience, that we're going to ask people to please, put their questions in the question and answer area, and just because we wind up not having enough time, and we're going to definitely schedule, whether in 2 weeks or 4 weeks, we'll reply to these questions live, and we'll collate them together and really give people good answers. But it's just in order to keep the information flowing from Dr. Bean, we're going to probably not answer questions and unless something really comes up that seems to fit the moment.
So for the audience, when I'm looking here, I'm looking at Dr. Eric, that he's on my monitor here. And when I'm looking here, this is my second monitor where the protocols are and my drawing board is. So I'm going to share my screen and start our discussion. So the first discussion that I want to do is the vaccine injury related management approach. So this is FLCCC's I Recover Post-Vaccine Treatment. This is hot off the press. I think they published it this Wednesday of this week. Today is Friday. And I have participated in this as well. So let's start with post-vaccine injury. Long COVID has similar symptoms as well. So you could probably connect them both. However, there are some minor differences, not minor, some differences, important differences. The underlying problem is the chronic inflammatory state. And I have done some discussion separately. I have discussed this with Eric, you would like it, Dr. Bill Murphy from UC Davis. He is an immunologist, he's a PhD in immunologist, and he discussed why patients get relapses and remissions. So those are separate discussions, but imagine if a patient has ended up in that state. How do we start? So let's start right off the bat here. First line therapies, and I'll briefly explain why this may be interesting, and the explanations are in this document as well. So intermittent daily fasting, I did a talk about that as well. What happens is that with the intermittent, it's not only reduction of energy to the immune system cells, which then do not find enough energy and they kind of don't work as aggressively. Just like if we are starving, we don't work that aggressively, right? Not only that, but there is an interesting outcome, and that is when the energy levels or the nutrient levels are lower for the cells, then what cells try to do is they break down things within themselves to figure out what is it that I can use to stay alive and continue to function. It is very similar to us as a whole, that if we are hungry and we are starving and we are not getting food, we will break down things within our own body and use them. The first things are circulating glucoses or glucose storages present in liver, for example. Then the second level is going to be mobilization of fats and utilization of them. Third level will be when all else is gone, then we'll start eating up our own muscles, which is the last thing. Our body doesn't like to do that. Just like that, the cells would look inwards and find things that they can break down. In that process, they would try to break down those things that are not really there, like that is like fat in them. It's not really fat, but things that are extra. They'll try to break them down and convert them into energy and use them. If they cannot find such things, then they would start digesting their own organelle as well. So that is not just a starve the cell so it is not functioning correctly. Now you are asking the cell to clean its house. In that process, if there is a virus sitting in there or is there a spike protein sitting in there hiding in the cell, they break that down as well. So intermittent fasting can actually help dysregulated immune systems to become regulated again. Beautiful mechanism. The second thing that is interesting is, and I hope you catch this mechanism. This, when I studied and researched this mechanism, it blew my mind. That is this. Imagine, let's take Dr. Patterson's discussion, research that in the monocyte, there are spike proteins hiding in there, stuck in there, not getting digested. Now imagine we starve that cell. The cell is going to look inward and say, what extra things do I have to break down? And it's going to find that spike protein and break it down. Not only it breaks it down, but it actually presents it on its surface as well. Whenever a cell breaks down things inside, it always presents them outside as well. All of a sudden, this cell in which the antigen was hiding is not only breaking it down, but also presenting it so that the immune system cells can come and help it or kill it. What a beautiful mechanism. And then in addition to that, when the intermittent fasting is done, then that causes the cells to activate their apoptotic channels as well. And these cells will die if they are not necessary cells. And our body knows that which immune cells are just sitting out there being active, not necessary. It would kill them. So this is a very interesting thing. And I have done a separate discussion about this as well. So intermittent fasting is one.
Yeah, and I would just add that this goes along with when your cell is ill, it becomes more dependent on glucose. And so this is one of the people who listen to me talk and other places know that I'm very big on Dr. Bob Navio's cell danger response, or pathways. And in during the first and second parts of the healing cycles, the cell, it has difficulty getting energy from the mitochondria, and so you really need the glucose that you get from eating. And so when you starve, and those tend to be the sicker cells, you're going to stress them, and hopefully they will then go apoptotic. And so this is just another way of looking at the same mechanism. It's really quite elegant how the body works. So
Yeah, absolutely. And I use your example as well to say, you see hummingbirds, they need glucose all the time. So active cells are like hummingbirds. They need glucose right away because they're really working very fast and hard. And if you take their glucose out, they're the first ones to go down before the other regular resting cells. So very good. So fasting is one. Of course, ivermectin is another one. We have done the mechanisms many times. One for inflammatory control, and secondly, possibility of connecting with the spike protein if spike protein is running around somewhere.
right.
Low dose naltrexone. Interestingly, low dose naltrexone with its anti-inflammatory behavior, and this was actually, I mean, in high doses it is for addiction, but in low doses it's such a marvelous thing for not only the inflammation control but neurological symptoms. I am seeing a majority of the patients after vaccine injury who use naltrexone feel better than leave naltrexone. Unfortunately, they get relapses more often, and then they have to be on a maintenance dose. I am still hoping that they would eventually be able to quit naltrexone. But if you are using naltrexone or feeling better, try to be, don't just abruptly stop it. I've seen remissions from this.
Yeah.
So just continue for some time.
Yes,
And again,
yes.
these are not medical advices.
Yeah, but
Sorry,
just
Eric.
6 months. I mean, we've used low dose naltrexone in chronic fatigue and chronic, for like 20, over 20 years. And usually if you respond 6 months to a year, because you're gently talking to your immune system, you're keeping it, you're modulating it, and like I said, you take it off too quickly, you'll bounce back.
Correct. And Paul Hood said, what about taking meds on an empty stomach, for example, aspirin during fasting? So don't, because it can cause stomach irritation. So at some point you're going to eat, and then you can take medicines at that time. Or you'll have to figure out a balance of how to fast and take these medicines. That is why it is important that this is not prescription area. This is more of an educational part. Then you sit down with your doctor, look at your situation, and decide what is the right thing to do. Melatonin, we have seen this beautiful drug with supplement with the anti-inflammatory behavior, with the antioxidant behavior, with the restoration of mitochondrial behavior, which is very, very important.
Yes.
It is the mitochondrial dysregulation which ends up letting the inflammation run away. And the reason for that is that when mitochondria are working, not only they are producing ATP, which if they are not producing ATP and ATP is produced in other pathways, then acidosis occurs, which is dangerous. And the second thing is, if mitochondria are not functioning correctly, they do not make anti-inflammatory and reactive oxygen species neutralizing products very well. So I have done a complete video about this, that there are certain enzymes that get turned off when the mitochondria are not functioning correctly. So as soon as you give melatonin, melatonin would help mitochondria to function correctly, and all of a sudden energy levels are restored, oxygen utilization is restored, and inflammatory system starts becoming normalized. So it's a beautiful, important thing. Aspirin for clotting issues, vitamin C, vitamin D, quercetin, we know these from our previous discussions. So here the backbone in this one is ivermectin, intermittent fasting, low dose naltrexone. And important aspirin, depending upon you and your doctor, and if there is any clotting, D dimers are present or not present, if you can take aspirin, or if there is a risk of bleeding, all those factors will have to come in to look at that. Now, continuing, I'm going to go to the next page. Then Nigella Sativa. This, well, at least in my culture, we are used to taking Nigella on a regular basis. Nigella Sativa is said to be that it has the cure for almost everything other than the death. The basic thing is it actually has anti-inflammatory potencies, and it has been shown to be very effective in chronic inflammations. So Nigella Sativa, and on Amazon, again, I'm not selling it. I don't have Amazon link to give it to you, but on Amazon, one can buy Nigella Sativa oil, or you can buy the Nigella Sativa itself. Or these are also called black seed oils. Then probiotics and prebiotics. So there was a recent study that showed that the SARS-CoV-2 can act as a bacteriophage and infect the bacteria of the GIT. So just like the SARS-CoV-2 is infecting us, it can infect the bacteria, which in turn would cause dysregulation of our normal microbiome in the gut. And of course, that would cause immune system dysregulation plus GIT functional dysregulation, plus the imbalance would cause the nitrogen production and so many other issues, which in turn have their side effects. So it is important that prebiotics and probiotics are taken as well. So interestingly, this evening, I have, Eric, a discussion with Dr. Sabine Hazen, who is a gastroenterologist, and she's very big on prebiotics and probiotics as well. So we'll see how that goes.
That would be very, very, very interesting, because the gut is the key. And just to remind people that we always like to give things names that confuse everybody. And a bacteriophage is just what we call a virus when it decides to infect a bacteria.
Correct.
Always confused me. I thought it was something different for years.
Yes, it is the virus that infects the bacteria. It's called bacteriophage. So the name has bacteria. So yes. Magnesium, and especially if you're taking calcium as well, then magnesium or zinc as well. Sometimes you have to separate them out so that they do not interrupt each other's absorption. Omega-3 or fatty acids is very important as well. Now, adjunct or second line therapy. So the first line's backbone was Naltrexon, ivermectins, Nigella Sativa, intermittent fasting, and then anti-clotting, anti-inflammatory based on your condition and your doctor's discussion. Now, second line, hydroxychloroquine. Once again, you know that hydroxy is related to inflammatory outcomes, plus it has effects on spike as well. So hydroxy is one. Intravenous IV vitamin C. Here, another important backbone other than the IVC is fluoxamine. Now, fluoxamine in some vaccine injured or long COVID patients, in some of them, it actually exaggerates the problem. So when they take it, they complain that, hey, I had more headache or more neurological symptoms, so just quit. Otherwise, it is a very, very good drug. It's just like LDN. LDN is better. However, fluoxamine has very good result as well, but not in everyone. Then mitochondrial energy optimizers. So pyrroloquinolines or quinones, these are some of the energy optimizer, just like melatonin. So these are also available. NAC, we have all heard about them. That is interesting as well. And so you see a lot more. Here is an important one, which sometimes I use as a first line, and I'll explain why. Low dose corticosteroids. Then behavior modification and Tai Chi or low exercises. So I'll speak about steroids in a second. Interestingly, both in long COVID and in vaccine injured, physical activity, stress, and hard work or hard mental work causes remission, triggers this problem. I've also seen eating old food that is sitting in the in the refrigerator for some days. Especially for these patients, they actually, if you speak with these patients on regular basis, their story would look like something like this. Number one, if I went to gym yesterday and now I have a remission, or I had a work related stress and I have a remission, or I was doing this planning, or I was buying a house or mortgage and I was doing the calculations, or for my office I had to do this and I have a remission. In addition to that, they would say, I ate carbohydrates and I have a remission. Or they would say, they would realize over time that I ate older food and I have a remission. One thing that is hard to detect, but is important to also notice, is high histamine diets. For example, tomatoes or eggplants or bitter things. These can also cause remissions. So I think what happens is, and this is my opinion, not a professional opinion, um, that when the food is sitting in the refrigerator, the bacteria, there may still be some bacteria making their toxins, and that may be low baseline, but that could cause uh, the immune system to react, and that can cause a remission.
And
So
this
behavioral modification, sorry.
No, I was going to say this is what the reoccurrence with the post-exertional malaise. I mean, this is why this is really physiologically the same thing as chronic fatigue, because it's the exact same issues when the body gets overly stressed. And the old food, again, bacteria, also mycotoxins, many people, just exposure to mold. Once the system gets sensitized and the immune system is no longer able to modulate its responses, mold exposure for normal people, or for people whose immune system is working normal, I shouldn't call it normal people, but it's nothing. But when the system is more sensitive, small things will stress it, and that stress is what will cause the recurrence of symptoms in people. So anyway, so that you go on
Right.
for.
Yeah. So the behavioral modification is that we will have to learn to be less stressed, or figure out how to prevent stress or avoid stress. We'll have to learn to become more happy in our day-to-day activities. We'll have to learn to do activities that make us happy, because otherwise we keep getting relapses. So it almost becomes a punishment for us every time we stress out. And we have to kind of scale ourselves back and say, okay, I'm not doing it. I know patients who say, I have learned that this thing stresses me out and I try not to do it. Or if I do it, I know that I'm going to be down for a couple of hours afterwards. So this is such an important area. It's not just true right here. And Tai Chi or light exercises also help as well. So that is the second line. Third line, hyperbaric oxygen therapy. This is, again, we didn't know that this would actually help this much, but there are patients who are so much refractory to many other situations, and they respond very well to hyperbaric oxygen therapy. Now, in addition to this, I'm going to talk about some of the other possibilities or other situations. One is tinnitus. Tinnitus is really bothering people both with Omicron and with vaccines. Tinnitus, I was surprised yesterday. I was presenting this study from Taiwan where they had managed tinnitus. It was one case. They had managed tinnitus in a patient who had received Pfizer BioNTech vaccine. And the researchers called tinnitus as a minor and reversible adverse event. And I disagree with them.
Yeah.
It's not minor. It
Yeah.
can drive people to suicide, and it is not always reversible. I think they had to say that just to stay in the good books of the authorities, that hey, we are not bad mouthing the vaccines. We said it is minor, it is reversible, and then they presented their case as well. So I think nowadays there is a political aspect as well, unfortunately, that has crept into the science. So tinnitus is a very common problem. The issue that why is tinnitus happening, there are many theories for them. For example, one theory is that there are ACE2 receptors that line the hair cells. The hair cells are the cells in the internal ear cochlear structure, where these cells, hair cells, are working to help us understand various frequencies of the sound. So if they are lined with ACE2 and if the virus can enter there and cause infection, that would cause tinnitus. That's one theory. There's another theory, and that is that immune system dysregulation that occurs with the virus or with the spike protein, with the vaccine, other adjuvants of the vaccine, that inflammatory state, when those antibodies and inflammatory molecules enter the inner ear, they can cause local inflammation. So cochleopathy, immune driven cochleopathy, or cochlea is the little bony structure in which the inner ear system is present. So cochleopathy can occur. And then a third theory is that the blood vessels are inflamed and the clotting is occurring, or microclotting is occurring. So the blood vessels of the internal ear are, of course, very tiny little. Internal ear itself is a very sensitive, delicate, tiny thing. And then, of course, the blood supply itself is very delicate in that area. So if there is a problem with the blood vessels or the clotting, then that would also cause compromised blood supply to the internal ear, and that would also cause tinnitus. So the research that I saw yesterday and presented, it was very interesting, in which what they did was they said our normal, so there was a patient who had tinnitus, and had put that patient on ceftriaxone, 1 milligram per week, and patient was actually becoming better. The patient went from tinnitus of patient not being able to work, tinnitus handicap inventory count in 90s, that means almost unable to do anything. From there, the patient had gone down to 12, I believe. That was ceftriaxone. Then the patient got the vaccine and went back again to 96 after the vaccine. So they started the patient on their regular therapeutics for tinnitus in the ENT department, and that was give corticosteroids, IV stat, dexamethasone 10 milligram, and then they did a follow-up with prednisolone 5 milligram thrice a day for certain days. And they said it failed. The patient went from 96 inventory to 88, which was still in the grade 5, which was still disabling, which was still very, very high. They said we started the RTMS, repeated transcranial magnetic stimulation. And apparently in the US, it's an FDA approved thing. And in the US, one can even buy those devices. Again, this is not a medical advice for anyone.
Yeah.
For $500, the devices are present that do the RTMS. Anyway, so they did the transcranial magnetic stimulation of the brain. And how did they do? They had 10 hertz wave. So the wave was 10 hertz in frequency. And they gave 3,000 pulses every day for a few days, I think for 15 days. And the patient's tinnitus handicap inventory went down from 88 to 6. 6 is almost recovered. 6 is I have 6 or 10. I have tinnitus as well, and it doesn't bother me. So that is what so Annette says, spell the drug used for the tinnitus. So they had used ceftriaxone, that is actually an antibiotic.
Yeah.
And then they used dexamethasone and prednisolone. That didn't work. And then they did RTMS, which is repeated transcranial magnetic stimulation. Yeah. I hope that answers that question. So continuing. So for tinnitus.
Oh, okay. You finished. Let me.
Yeah, please go ahead.
No, I was just going to say, because things that are interesting is ceftriaxone is also known as Rosefin is the brand name. And we use it quite a bit for Lyme disease. And there was a study years ago that showed, people got better on intravenous ceftriaxone for 6 months, and then they stopped it. They got worse again. And the theory was that since it hadn't eradicated Lyme, but it actually works by reducing glutamate toxicity in the brain, which will also exacerbate these. I'm wondering if that was happening, and the transcranial neural stimulation is just fascinating because it is approved for depression in the States, and there's so many different ways of doing this that it's available. That really should be, expanded upon. That would be very
Correct.
exciting. Okay.
Correct. So that's what they said, and their takeaway was that in the animal models, RTMS, or transcranial magnetic stimulation, has proven to be helpful for the brain in immune inflammatory states. And they said, we don't actually know the mechanism. How does the magnetic stimulation help brain's immune system or circulation? It seems like, I was talking with Dr. Paul Merrick this morning, there are some studies that say that the blood circulation improves, which would also mean that lymphatic circulation would improve, which would also mean that there is more nutrients coming in and more garbage taken out, which would also mean that if there are inflammatory molecules, they may be washed out quickly. So the whole thing will become freshened up.
Yeah.
So
you definitely improve, using, there's a multitude of treatments that are now used for neurostimulation: light, sound, magnetics, electrical. And I mean, the data, lots of people are using this. The biohackers are very big on this, but there's more and more data on it that's slowly coming out. And all of this increases, from basic research, that it increases mitochondrial function. And from there, everything else improves if the system can handle it.
Yeah. So maybe this does that.
Yeah.
So, so the result was that one patient, so in the animal studies, they had seen that immunopathological or immunoinflammatory state was improved. And then they said in this case, one case, they found that this was also vaccine caused immune mediated, inflammatory state in the brain, especially cochleopathy, which was improved. So I took a little more time on tinnitus because this is something that is bothering people a lot and making them very disappointed, and some of them end up near. I had a patient, I had a person who herself is a patient reach out to me yesterday and said that there was another patient who reached out to her and said, I have such a bad tinnitus that I want to kill myself. And she told that person that there is hope available, there is help available, there are therapeutics available. And she kind of pulled him back from that situation. So tinnitus can really drive people.
It's bedeviled people for a long time because there's no one treatment that works for everyone for tinnitus, and it's a real just an issue. And again, you run into the problem that the ear, nose, and throat doctors usually will try one or two things and then kind of give up, and you as the patient have to keep looking. There's lots of treatments and they don't work for everybody, so don't give up. That's the hardest thing of these symptoms. But by the way, have you, I haven't myself had much success, but I've heard other doctors talking about that the low dose Luvox, the Fluoxamine, has helped some of their tinnitus patients. But
So it has in some cases, but in some cases it has exaggerated. So this is going to be a trial.
Yes.
Try, and then if it doesn't work, then withdraw it. Okay, so this is the one treatment plan you're seeing, or the way to manage, and I am actively a participant in this one. Now, the next one, we have seen the iRecover protocol. It's just interesting here from an Mcas point of view. So today's topic, one of the topic part was in the long COVID or vaccine injury, if there is a mast cell activation, then how do we go about that? I actually think that Eric can do a better job than me on Mcas because you work with the long COVID, chronic diseases. So do you want to take this one, Eric? Or do you want me to present it?
Well, I can, say that in a subset of people, the MCAS is a big part. Again, the problem with this illness is that each one, like all these chronic illnesses, as a practitioner, you see a small number And it's so, it's hard to generalize to the population, but I think anyone that has multi-organ complaints, what I mean, if you have migraines, if you have gut issues, if you have bladder irritability, if you tend to rashes, if you tend to lots of allergies, if you have, any one or especially two or three of these for sure, doing really using the antihistamines and the mast cell stabilizing herbs and medicines that you had there. The quercetin is a very big one, right up on the top of the list. It's worth trying. I mean, it really can make a difference, but I still think that usually you're going to have to go a little bit deeper to really get better.
So here is to add to the discussion.
Yeah.
Here is a list of meds that are here. So again, the basic problem,
Yeah.
when the mast cells are active, there is histamine that is being released, and then the histamine has its issues. And there are other things as well, prostaglandins and so on. So how do we treat them? Here, the treatment of acute episode should follow the recommendation of treatment for anaphylaxis. So we leave that apart, because if that happens, that's going to happen within the vaccination center. Antihistamines, one can give type 1 or type 2. Type 2 are preferable. One can also give cell membrane stabilizers. So in the type 1, again, there are two categories: those with slightly more side effects and those with the slightly less side effects. The problem is that a patient may be on an antihistamine 2 weeks feeling great, and then the same antihistamine isn't working and they need to switch it up. Because of that, having this list in front of you is interesting. So here, for example, type 1 receptor blockers, diphenhydramine, hydroxyzine can be useful for itching, abdominal discomfort, and flushing, although the side effects of sleepiness, drowsiness are more. Second generation antihistamines, including loratadine, cetirizine, fexofenadine, are preferable because of less. Then if you go
And
to
just
the
to make it easier for people, that's like Allegra and Claritin and Zyrtec. Those are the ones over the counter. And the other thing I'd really emphasize, if your mast cell is significant and you seem to get, and nothing works, and these medicines actually make you worse, you're really going to have to talk to your doctor and get it compounded, because that's for once the mast cells are really active, many times the excipients, the chemicals that they put, or the binders that they put in these medications, actually are allergenic. So it's very frustrating. But so if you take these and get worse, talk to your doctor about getting them compounded.
Excellent. Thank you. So treatment with histamine type 2 receptors, such as ranitidine, famotidine, can be helpful as well, especially for abdomen. Now, interestingly, we know this, I think all of us, that aspirin is not only anti-inflammatory, it is actually an inhibitor for prostaglandin D2 production, which is also kind of going to help with the flushing, that the redness that we see. Then in addition to that, montelukast, zafirlukast, and so on. Corticosteroids can be used as well. I had said that I'll talk about corticosteroids, so they came up here. Let me do that.
Yes.
In the beginning of the disease, it may be needed to have a low dose corticosteroid therapy. So 5 milligram prednisolone twice daily or thrice daily, and then tapered to, let's say if you're giving thrice daily, I'm talking to the doctors, then a week later, make it twice daily. And when you are reducing it, reduce towards the earlier part of the day, not in the later part of the day. So breakfast, lunch, dinner for a week, then breakfast and lunch for a week, then breakfast only, and then quit. I like to do this because it kind of gives patients some more time with the steroids. It's not necessary to taper this smoothly for such small doses, but still, I like to get the benefit of tapering plus the benefit of a little longer usage of the steroid at a very, very tiny dose. Some doctors feel that the earlier use of corticosteroids in case of a vaccine injury or long COVID may not be advisable because there may be a hormonal dysregulation already present, and that may be suprarenal dysfunction going on, and then without knowing the steroid levels we shouldn't add more. So that, I think, is from case to case. One can decide to have those labs done first or decide to put patients on these, depending upon the patient situation. So I am a believer and a user of steroids first. Why do I do that? So I gave you the caveat that there are some doctors who say, no, I'm not going to do it in the beginning. Plus, there is also a theory that if there is viral reactivation, for example, EBV has reactivated, and on top of that, you give steroids, now you're giving virus a chance to bounce back a little more. So because of this, some doctors do not prefer steroids in the early part of the vaccine injury or COVID injury, long COVID. My reasoning for using these steroids early on is that as steroids suppress the immune system, they give a chance to the body to start healing faster because that overwhelming immune system attack has become controlled. This can also allow some of the cells to die out who will not die if they are continuously active. This is an interesting behavior of our immune system cells that if they are active, they would turn off their apoptosis signals. They'll turn off their signals that allow them to die. And every cell has a signaling mechanism to say, I'm going to work for this much time and then I'm going to die. Or the neighboring cell can tell this cell to die to say, hey, you've done your job. We are regulatory cells. You need to go away now. And the cell would cause apoptosis and die. And in case of continuous activity, cells turn off their apoptotic signaling mechanism. So even if you're poking them and saying die, they would not die. They would simply say, you know what? I am immortal. I am needed. I need to work here. I'm not dying. So to such cells, if you give steroids or any other way of modulating the immune system to kind of calm them down and not have lots of work done by them, then they would turn on their apoptotic signals and respond to the regulatory signals and die. And that is important in chronic inflammation or inflammatory responses here. So because of that, I usually try to give a rest to the immune system by starting with the corticosteroids in addition to LDN, and then just leave the patient on LDN. So that is very specific approach of mine.
Yeah, no, I think that's reasonable. I will often be, because my patient population is on the one end of the spectrum, that so many of them will get agitated from steroids, that but usually the 5 milligrams just in the morning, most of them will tolerate. And I do agree, I've always been a proponent of or if they're very sensitive, maybe using smaller doses of hydrocortisone, which doesn't last as long, because these medicines at low doses are immune modulating. I don't really feel that it's not like a total wet blanket. The doses that most doctors use of 40 and 60 milligrams of prednisone, those are wet blankets. They just suppress everything. But when the doses that you're talking about, I really do believe are more immune modulating, and so you don't have to worry too much. I don't think you're going to hurt anybody as far as allowing an infection to flare. That was a big concern amongst the Lyme community for a long time, and it still is. It's part of the lore, but I don't think it's a big deal at the dose you're talking about.
Thank you very much for chipping in, because pitching in, because I didn't want to start a new controversy. I think that steroids in the beginning, low dose, are important, but again, your doctor could decide differently, and that is okay. And as you heard, Eric, maybe 5 milligram once at the breakfast, and that is good.
It's all about the sensitivity of the person, and we're all very different.
Right. And finally, on going back to the Mcas, Malizumab, which is an IgE receptor blocker, so that can also help. Yeah. So this is something about Mcas. In Mcas, I would add one more thing, which has to be really you have to be mindful that you don't end up with the um, or your patient does not end up with malnutrition, and that is to try to reduce the uh, histamine rich diets. But histamines are everywhere.
Yeah.
So trying to reduce means almost for the patient not to eat anything, and that can cause malnutrition.
Yeah.
However, more common one like tomatoes or eggplants or other bitter things or sour things can be reduced for some time because they can also cause triggering of this situation.
I don't know if you mentioned cromolyn in there. People can try, cromolyn can be very helpful orally as a mast cell stabilizer and antihistamine, and sometimes DAO, diamine oxidase, which is an enzyme that your gut makes that breaks down the histamine in the gut. Sometimes that can be helpful for some folks. I don't know if that's
Absolutely.
on there.
Thank you very much. So over here, there are, in addition to what we just spoke, there are some medicines here as well that are for the histamine. Okay, continuing, we talked about tinnitus as well. Now, a little more about the Dr. Resia Pretorius's um, process. And I also want to talk about IVIG and I want to talk about electrophoresis if we can. What time is it?
Oh, we
So
got, yeah,
we are,
we're going to have a little hard because we have also skipped over Dr. Patterson's treatment regimens, but
yes.
that's too
Yeah.
much
So
to,
let's go to
can't
Dr.
do everything.
Patterson's regimen first.
Okay.
So if you're okay, you tell me if you
Yeah,
would
no, I
like.
think that's good. I still,
Yeah.
hopefully we can get, I'm going to watch the clock. We're going to get 5 minutes for Dr. Pretorius's stuff, no matter what.
Yeah. Okay, perfect. And if you would be okay, me going over the time, I'm fine as well. It
Oh,
really depends upon you and your
I'm
audience.
fine. It's just, yeah, I want to be respectful of your time. So that's it.
Yeah, I
I'm
have time.
oh, good.
Today, I do not
Okay.
have a meeting afterwards. So totally up to you. So let's go to Dr. Patterson's protocol for a second. So I
Yes.
don't think it is their protocol. They, I believe, Incel basically says that, hey, we have these labs, and
Right.
then related to the labs, there are various ways to manage, and the management that they have patented is the what is that, Muraviroc.
Well, yeah, I look at that as one of a series, but I think their labs, uh, they just made me think, and I think a lot of people think in creative ways. I think that's what's exciting about their
Correct,
laboratory.
correct. So Muraviroc is their patented. In addition to that, I'm seeing doctors also using statins. So if I look at their primary, some of the doctors' primary way of working with Patterson's uh, protocols is they get the labs done to understand a baseline, and they have a specific interest on CCL5 and VEGF, vascular endothelial growth factor, and the presence of VEGF indicates that inflammation is so much that the tissue is trying to generate new blood vessels to bring even more supply of the blood to create even bigger war over there.
Yeah.
This is like if you have a war zone and you build new roads to bring new armies there to the war zone through those new roads. So vascular endothelial growth factor is actually something that would help a blood vessel to create branches. It's not an endothelium that is only growing. It actually creates small, tiny pouches. Let me actually share this. I, it's easier for me to draw.
Some
So if,
artwork, yes.
yeah. So imagine if there is a blood vessel here and it is going, it is entering a tissue from here and it is exiting here.
Your screen isn't sharing yet.
Oh, okay.
Let's see.
So what am I sharing? So let's try it again. Here and here. Do you see it?
Not yet. I'm not. I don't know if anybody else is.
Okay. So Gunnar says we can see it.
Oh, you
Margaret
can
says I
see
can
it. So it
see
must
it.
be me. I don't know.
So it is you. All
It's
right.
me.
So
That's good. That's good. I'm happy. I'll guess.
so here are the blood vessels. And this is the surface cells of the blood vessel. Inner surface cells are called endothelium. When there is inflammation going on in this area or somewhere else in the body, but let's say inflammation is a lot, then what happens is vascular endothelial growth factor or VEGF is released by the local tissue immune cells or warring cells. This VEGF has many functions, but one important function is to act on the endothelium. And it kind of converts that endothelium into a I'm being loose now, stem cell, into a stem cell like behavior. That is, this endothelium is going to start making more endothelium. But it's not that it's just going to make a pile of endothelium within the blood vessel and that would just kill the blood vessel. Instead, the endothelial growth factor starts causing production of a blind outlet from this blood vessel. And then slowly that blind outlet continues to grow more. And this is actually the production of a new blood vessel. Finally, this new blood vessel will be canalized. It would now be able to bring the blood in this area. So we have just made a new road to bring more blood and army and everything. And this happens in the tumors normally. Tumors are very big on producing VEGF so that they can have a lot more blood supply to them and a lot more nutrition to them. And Dr. Patterson's labs, one important factor in there is VEGF. The other one is CCL5, and CCL5's function is it is a remote control for T cells and other immune cells to come to the area of inflammation and fight. And so if we are already suffering because of inflammation and you release CCL5 and you release VEGF, that is going to cause a lot of local damage. And that damage is going to continue to be intensified instead of going downwards. And that also means that in the local area, the regulatory cells, the cells whose job is to stop the inflammation, they are not able to do their function anymore because they're overwhelmed by the active warring cells. The warriors have overwhelmed the controllers. So here, after understanding this, what Patterson's protocol, I don't know if he would like us to call it his protocol because he says that doctors can decide what needs to be done. We are offering a set of labs. So basically, based on those labs, every doctor, Eric, would have his own approach to say, all right, I see following markers to be high. I would want to do following therapies. But their own more commonly used therapies are statin and Muraviroc. Muraviroc is a blocker for CCL5-like things. It is actually used for HIV. However, it has been very, very, according to their research, it has been very much effective for those monocytes that are carrying S1,
Right.
to kind of encourage them to die away. So that is a basic protocol.
Right. And one of the other marker that they have on their panel that's often elevated, at least in the population I see, is this something called soluble CD40 ligand. And it's related to platelet activation, which interesting will maybe segue us over to Dr. Pretorius's work because I have found, I used a lot of the statins and a lot of Maraviroc for a while, and I still do, but I'm finding that many times since the soluble CD40 seems to persist, that I've been using more Plavix, whose generic name is Clopidogrel. It's a drug that I hadn't used in like 25 years. It used to be very popular in the early 90s. Everybody who got a stent got this medicine back in the 90s. And, but I found it surprisingly effective because it's a platelet stabilizer and it has effects on the purinergic system, but that's another subject completely. So, but going on, so let's get over to Dr. Pretorius's work because I think that
absolutely
is a window into things that is, I think, more important than we realize, at least than I realized.
So I'm going to go back to my drawing board. In Dr. Pretorius's observations, what she saw was, and there's a very decent paper that she's written, what she saw was that there is a lot of fibrin and platelet activation that happens. And this platelet activation, so platelets are part of the bloodstream as well. They are platelets, they are tiny plates. They actually are built in the bone marrow. So let's say this is bone marrow. Our bone marrow is actually a set of, it's a tissue, a lot of cells. But interestingly, bone marrow, whenever I think about bone marrow, it horrifies me. This is like a prison with little bars, sharp bars like knives, which cut across the bone marrow and create a grid or matrix in here. We call them trabecules, and then the bone marrow's connective tissue. Now, what happens is inside this strange place, there are cells that are called megakaryocytes. The mega actually means that they are big cells. I hope I can. So these are megakaryocytes, big cells. When these megakaryocytes develop, they become very wobbly and they become kind of uh, squishy and so on. And from them, as the blood zips near them, small tiny plates eject or break off because these megakaryocytes themselves cannot come out of this prison in which they're stuck in a barbed fence. So what happens is pieces of them break off and join the blood circulation. These pieces are called platelets. These tiny little plates that break off like little droplets on the megakaryocytes, they contain enzymes in them that help them uh, do clotting. Now, platelet factor 4 is a protein that is present inside the platelets and can be released by the platelets. So imagine the platelets are zipping around in the blood, and next to the platelets are tiny little baby platelet factor 4s as well that are circulating. They're chasing them, just like in an ocean, the mother whale is going, and then there is a tiny baby whale chasing it as well. So what happens is, in case of long COVID and both in vaccine injury, it is actually possible that for the antibodies to attack the platelet factor 4s or even attack the platelets. That in turn causes the factor 4s to become activated, which in turn would cause the clotting or microclotting to start. Now, if there is a tiny little microclot within the blood vessel and the blood vessel size is big, this clot will not do anything. However, at some point, these blood vessels would continue to divide into smaller and smaller blood vessels. Eventually, the diameter will become small enough that that clot will get stuck. And as soon as the clot would get stuck, onward blood supply to whatever tissue was downstream here, that blood supply would be compromised. And that is where the symptoms would start appearing. And those symptoms could be neurological symptoms, or these could be cardiovascular symptoms, or liver, or GIT, or whatever tissue is involved, there'll be symptoms of that. So Dr. Resia Pretorius, what she does is that she, just like electrophoresis, you bring the blood out, she brings the blood out and cleans out these factors and the um, platelet factor 4 and removes the fibrins. And the problem is that when the fibrin is activated in here, according to her research, then this fibrin and these platelets start sticking to RBCs as well, meaning not just with each other, they start sticking to other blood vessels, blood cells too. So that causes even more problems because now we have a problem with the RBC. Then she says that in the labs, we do not see those factors and the inflammatory molecules. And the reason for that is that even those molecules are trapped in these little microvascular clots, not microvascular, but microscopic clots. And so because the molecules are trapped in here as well, we cannot see actually these. So what she does is she does an electrophoresis like activity, and she cleans out the blood. I actually think, Eric, that this process of helping the blood from cleaning is very, very important for two reasons. One reason is that It would allow, for example, antibodies to be removed. It would allow these clots to be removed. It would allow these extra inflammatory molecules and platelets that are activated to be removed, if possible. Depends who is removing what. Various doctors are removing various things,
Yes, yes, we're all learning.
right? So it's not that this is a uniform process.
Yeah.
The second thing that is important is that as you remove the, let's say antibodies, we take them as an example, or microclots, you take them as an example. As you remove them, what you have done is all of a sudden you've taken the offending agents out. Now, imagine with me, or let's draw. Eric, were you able to see the screen
Yes,
last time
yes,
or not?
the screen came on. It was just a
Okay,
momentary, I don't know, glitch, but it's working
got it.
fine. I can, yeah.
Okay, so imagine with me that here is what happened. Somebody got vaccinated or had COVID, something that caused an unknown trigger. This, by the way, is still being figured out what it is.
Yeah.
This unknown trigger caused immune cells to become dysregulated. Now, what is the mechanism of dysregulation? There are many possibilities. I'll give you one simple mechanism, and that is that when immune system became active because of this trigger, let's say this trigger was spike protein, when the immune system became active, active cells, they were increased in number. We call it proliferation of the cells. And now they're all attacking and sending in molecules, and they are attacking the tissue and blood vessels and so on. And then come the regulatory cells, and they say the regulatory cells tell these active cells to say, guys, you need to stop. And the active cells would stop. And this is how the inflammation would then be removed, or homeostasis will be accomplished. Similarly, there is the network hypothesis that I discussed last time. So you can hear that it is possible that the network effect would come into play and the antibodies will be cleared out. So the message here is immune system becomes active, then it becomes normalized or homeostatic. The problem is sometimes the active cells overwhelm the regulatory cells, and now regulatory cells are not able to stop them. Or, now please listen to this, even if the regulatory cells are able to stop them, the trigger has not stopped. So if you give any chance to this immune system, for example, you eat some food, or you go to an area of where allergens are present, or you do some activity that triggers the immune system, then all of a sudden these cells that were active will once again increase in number and overwhelm the regulatory system, and once again will have a relapse. Now, the third stage is that once immune system is active, it's going to make a lot of antibodies, and it's going to make a lot of cytotoxic T cells, correct? CD8 positive T cells, or CTLs we call them. And this is the B cell and the plasma cell side that is making antibodies, correct? Now, what is happening is, in case of electrophoresis, or in case of, let's say, Resia Pretorius, clearing out the clotting factors, or those microscopic clots and so on, what they're doing is these antibodies are in the blood. These antibodies and inflammatory molecules in the blood are also causing, let's say, microclots, fibrin production, and then the antibodies, let's make some antibodies here. So what we are doing is we are putting some filters here to say, you know what, let's remove these guys. Now, removing them is beneficial because these things themselves, for example, wherever the antibody is going to sit down on a tissue, it is going to cause inflammation there. If the antibody is going to bind with the tissue, so right now the binding sites are here. Imagine if the binding sites are on this side, that means it is bound to the tissue, it is attacking the tissue, it's an autoimmune outcome. Either way, inflammation would occur. Similarly, if there is platelet factor 4 activation, then the inflammation within the blood vessel or the clotting is occurring. Now, clotting, as we saw, could then compromise the blood supply to various parts of our body. So when we clean out these parts, what happens is we remove antibodies, which in turn reduces inflammation because antibodies are not present to continuously attack the tissues and result in inflammation. We also remove the clotting factors and fibrins present so that the patient's blood supply compromise to various tissues is removed. So will patient feel better? Absolutely. Now, will this clearance give a chance to this system to calm down a little bit because there was an amplifying function? Immune system dysregulation created these things. These things in turn enhance the immune system by continuing to attack the tissues and other places and calling for more immune system activation. So once you take out this part, then it is possible that this part would start calming down, regulatory system would start becoming active, and patient would start feeling better for a long time. Now, if the patient's trigger is not gone,
Yeah.
then after a few months, the same thing would reappear. But if the trigger had gone, but immune system was in a dysregulated state, then doing this would give a great chance to this immune system to become reset. So this is how electrophoresis, or this is how Dr. Resia Pretorius's work helps, that it kind of allows, it does function in two major ways. Number one, it reduces the immune system's products that have been produced from attacking the tissues. So that is going to cause symptoms and tissue damage. And number two, attacking the tissue activates more inflammation. So that positive vicious cycle, sorry for my passion, uh, is is continuing. So this clearing out would help there. And the second help is that the immune system itself would start regulating because it would calm down.
Yeah.
Now, the final thing I want to talk about today, and this is a very important topic, and this is a very scary topic as well, and that is this. Imagine, if I share my screen once more, my apologies for continuing to share. So imagine this is the situation. Some patient has this situation and they are attacking here. They're doing electrophoresis, they're removing their blood clots, they're removing platelet factor 4s, antibodies are doing those things, and they are becoming better. However, it is not about the immune system dysregulation, it is really the trigger that is still present.
Right.
And we can have a separate discussion for why is it present, what is the trigger, and believe me, if we knew more clearly, we would just go directly to the trigger and remove it. So here, I'm going to stay at this stage. Imagine the patient got the treatment and the symptoms came back. That means the immune system is still dysregulated or trigger is present. If immune system is dysregulated, then why is it dysregulated? It is dysregulated because there may be memory cells that are sitting in the bone marrow and continuing to activate other cells over there, and those cells activating these cells. And so there is a loop going on. To control these, the extreme case is to do chemo. And so that is a scary part. And I am seeing some doctors actually asking their patients to say, well, we did this electrophoresis, the situation, the symptoms started coming back in 2-3 months. It looks like you have cells that are sitting in the bone marrow, memory cells that just are not stopping, and we are not able to kill those cells. So let's do chemo, which would actually kill out a majority of such dividing new cells. This is why chemo is done for tumors, because it kills the dividing cells. And so maybe by doing the chemo, we'll be able to kill those active dividing cells wherever they are, and then you would have a bounce back of the normal immune system cells. So this is another part, and of course it is scary. And I forgot to mention prebiotics and probiotics are very important to restore the gut health, because SARS-CoV-2, not the spike, but SARS-CoV-2 could cause bacterial damage.
Yeah. I think this is, I said, a fascinating discussion. And once again, just shows that we have the same issues in chronic fatigue and chronic Lyme, but especially chronic fatigue, because they've done these same processes. We've done apheresis. They've done I think in Denmark, they've done a bunch of studies with, actually chemotherapy. Again, with not great results, to be honest. There's been a few, occasionally it works really well. Rituxan was a thing that was used for a long time. Again, something worth, if you ever want to have a discussion about the way that the system makes life difficult for patients. Rituxan is a good example but anyways, I'm sorry, I don't want to digress, but there's just, I think we have to, the important thing is we just have to start figuring out who's who. And that is the problem. I think the first steps that you and I are both talking about doing are wonderful because they're basically safe. We're not going to go wrong with the first 90% of everything we talked about today. Just trying it with this doctor's supervision, you're going to be fine. It's just that as we get more invasive, we have to then hopefully get more data. And I'm looking forward to that. And but it's going to be difficult because these things cost money, and at this point, the NIH seems to be spending more money in trying to figure out whether graded exercise is. I'm hoping they're not going down that way, but I wouldn't be surprised if they don't waste a whole lot of money to see if graded exercise will help people with long COVID.
So there's a comment from Diane Easley. Chemo is very damaging to the immune system and would likely cause more harm. Immunotherapy treatments are worth researching. I understand that, but again, this is a position that many doctors are now taking whose patients have been refractory for everything else and are severely injured and their lives are at stake. And so in those cases, the doctors are saying, for us, the last resort is to try to do the chemo.
It's
so
always
that
risk.
means they tried everything else and they couldn't find it.
Yeah, risk benefit is always what has to be, just like, the same question we have of the vaccines, risk benefit. If you're old, the risk is well worth it. If you're young, then there's a conversation that has to be weighed out just on your level of what damage you want to play with. But as unfortunately they say, COVID often has similar dangers.
Correct.
But so I thank you so much. I mean, it's just the depth that you go into the pathophysiology, I think helps people think about what the possibilities are. And especially, I hope that we get this to doctors so they can begin to think about this, because it's so hard to find information, to let the thought process roll. So again, thank you so much, Dr. Mobeen. Dr. Mobeen,
Dr.
Said. I don't like
Dr. Bean is totally fine.
Dr. Bean will make it. Okay. And we will publish it. I was thinking if you had time, perhaps in 2 weeks. I don't know if you're available or not. If we didn't really nail a date down from when we can just deal with people's questions. Hopefully the ones that have been written in, and just make sure we give a little, well, not too much confusing answers, because I'm sure people have a tendency to ask about them. And that's difficult because we really can't practice medicine on YouTube. It's just not a good idea. You can hurt people that way.
Right. So I think, so I was planning to travel. I would let Melissa know. She has my calendar. If I'm not traveling or when I'm back, she will discuss the date. So maybe in a couple of weeks we can do this. And for the audience, if they can give us the questions before, it allows me to be better prepared.
Yes. And I just want to remind everybody that your YouTube site, and you have another site as well. You have a tremendous site for medical information for people who really want to learn immunology. I recommend your site if you have it up.
So my site is drbean.com. This is where about 1,000 videos are present, and the price is less than $100. So that is very good. And then on the YouTube, you will be able to see Dr. Bean. Actually, here is one of my own videos here. And so this is Dr. Bean Medical Lectures on YouTube. So whichever way you would like to learn more. For example, a few days ago, I did this video. This is the vaccine caused tinnitus. This is what we discussed here as well. This is vaccines fail to confer good protection from long COVID. This is a very interesting study that shows that the vaccine only protects 15% more than non-vaccine from long COVID. And then we talked a few days ago about the NIH and NIND study. This video is very interesting. This is Dr. Bill Murphy talking about why do people with the chronic diseases continue to get the relapses and remissions and what is going on. So some interesting things there.
Again, recommend, great place to learn and study and do deep dives and really get information without the normal, unfortunately, what has become the normal bias. I really can't tell you how much I appreciate your ability to just, try to look at the data.
Welcome.
So, thank you so much. And we'll all meet again.